Okay. So, hi everyone, and welcome to this live session. Today we have a very distinguished speaker amongst us, and that's Dean Morbeck. I'm going to give a very brief introduction about him because I think all of us know him from his visits to India, from the Aspire conferences. I think you were at ACE as well, Dean. Am I right?
Yes, twice.
Yeah, twice. So, Dr. Morbeck is basically the scientific director of Fertility Associates New Zealand, and he actually looks after the science of these clinics in New Zealand as well as in Malaysia. They perform over 4,000 cycles, fresh cycles a year. And he's also worked with the University of Auckland as an honorary professor. He's worked with Mayo Clinic, has keen interest in quality of care, quality assurance. He's done a lot of work on KPIs and published a lot of work. So we're going to learn a lot from your experience today, Dean.
Okay.
Yeah. So today's topic is a little different. It's basically on the new normal. As we know now that most of us in India are now ready to start IVF practices. We've been shut down for almost 2 months. Just to give you a brief of where we are at, we've been shut down for almost 2 months, and there have been a lot of restrictions on non-emergency procedures in India, and IVF is one of them. And now the government has actually kind of phasing out those restrictions so IVF clinics can restart, the OPDs are restarting, and hopefully by June the procedures will also start happening again. And in the last few discussions which we had with Alpesh, we actually discussed a lot about HFEA and all the policies that HFEA has actually undertaken for management of clinics post the restrictions. But we know that there are a lot of different scenarios. We can't just follow the UK protocols. We can't just follow ASRM. We can't follow maybe even Australia, New Zealand, etc. So what we are trying to do here is basically give our viewers all the experience that they can get from all of these distinguished speakers, and then move forward with the practices. So, Dean, if you're there, I think your screen is a little hazy.
Yeah, I see that because you're lagging now too.
Okay, so I think we're having troubles with the connection from Dean. Let me, in the meantime, actually go through what we are going to talk about today.
Okay. I'll be back.
Hi, Dean.
Yes, Keshav. Let me, why don't you go ahead and go over that while I just...
Yeah, so we were just talking about the different kind of guidelines that exist, and I would like to actually know what your experience has been in New Zealand and how you've actually taken up cycles, because I know New Zealand was one of the countries which actually controlled the spread of the virus quite a bit. So your experience.
Yeah, so, well, first I need to have some disclaimers before I get too far. And the first is, obviously I'm not a virologist or a COVID expert. I do have scientific opinions about this, pandemic and transmissions. And the thing is most of the world is flying blind on this. There's very little known. There's remarkably little known about the virus and the transmission. What it's the most common route. We're getting more and more information, but because of this, a couple of things that I'd like to make clear. One is that you follow your local, regional, state, national guidelines, of course. And this is, as you just said, Keshav, that the HFEA, the ASRM, everyone has their own guidelines. That doesn't necessarily apply to you. And this is a fast-moving space as well, which means that we keep learning new things every day, and what we talk about today could be, wrong, and we could say we need to do something different tomorrow. So that's the other part of this discussion that's been challenging, because we like certainty. We're, as embryologists, we're used to being certain about what things we're doing, and there's a lot of uncertainty with this, pandemic. So that's those are some of the disclaimers. The other one is that because, as you said, I'm coming from New Zealand and Malaysia, But most of my experiences in New Zealand, because I don't get to go to Malaysia, here in New Zealand, we have a unique setting. We've had about 3 cases in the last 13 days. So
Wow.
we are, and those are all known from clusters. It's all, just contacts that we knew existed, some travel. So we're pretty well shut down. So, our government did a great job of jumping on it early. We're small, we're remote, we got it early. So because of that, we're really fortunate, which means that what I also have to do in my experience around the shutdowns is less than what everyone else is experiencing. Because so I'll just use those. I think that was pretty much it. Yes. So from this standpoint, then, in New Zealand on like March 23rd or 24th, I don't remember the exact date, we went into what we called a alert level 4 lockdown, which was, I think, the strictest lockdown anybody has taken, because we didn't even get to do carry out or take away food. So everybody had to cook their own meals, which is quite serious.
Their own dishes as well.
Yes. I don't know of any other country that did that level. And so the grocery stores are definitely a challenging place to go. That was a place you could go, though. We did have the issue of social distancing, of course, very well enforced. I did hear today, and I just want to make this comment, that it was on a podcast talking about the psychological impact of this, is that it might be better to call it physical distancing as opposed to social distancing, because we can still be social. The physical distancing is what's good. So we've done that. And
I was actually reading it in the ARCS guidelines as well. They've not mentioned social distancing. They've actually coined it as physical distancing. So you're absolutely correct.
Yes. Yeah. So in addition, then, so we went into lockdown, but we were able to finish patients who were being stimulated. So if they're already on FSH, they could complete that, which we know then adds another 10 days or more to the process. So that takes us, and we knew we were doing a 4-week lockdown. So halfway through the lockdown, we were pretty much wrapping up once you factor in the culture time, the getting embryos all the way out to day 5, 6, 7, biopsying them, freezing them. That ate up a large portion of the lockdown, and it ended up being almost 5 weeks of lockdown. And then we also were doing fertility preservation throughout, so we never shut down completely. We didn't turn things off. I mean, we did. We minimized our use of gases. Obviously, there's a lot of that you all would have done if you've been down for 2 months. We had to do that, but we didn't go to a complete shutdown. In Malaysia, we didn't at all. We just split to 2 teams and have been working throughout. There's been no shutdown there.
Oh, wow. So these are things that we are going to discuss in detail today. And I'm just going to show you the flow of today's live session. So I'm just going to add my screen to the live session. So today, what we've tried to actually devise for all of you is focus on a few points like safety, like resumption of the ART cycle. What are the points that we need to consider? Quality assurance measures, because obviously with the kind of experience that Dean has, I'm sure we're going to touch a lot about quality of care in whenever we restart. And we're just going to go back with a few take-home messages for all of you. So again, to all our 80 viewers who are out there at the moment, if you have any questions, we'll be happy to take. In the meantime, I'll be actually initiating that discussion. So Dean, when we talk about safety, there are 2 parameters that we actually have to consider, and that's safety of our patients, obviously. And the second thing is safety of our staff. So what are the kind of precautions that you guys have been maintaining in your clinics, both in Malaysia as well as in New Zealand? Because like you mentioned, you've not been shut down. So obviously there have been some major extra precautions that you guys would have been taking to actually do all of your procedures. So what kind of precautions are these?
Right. So I'll speak mostly about New Zealand, and that we have, and an important point about New Zealand is that we have a very low incidence rate. So I think, we're one of the lowest, although I would say probably Kerala might be even lower. That's done very well. And I did go to ACE at Cochin, so that's a really nice state. But the way we've approached safety is obviously observing what the rules are around close contacts, both between staff and with patients. And the rules with close contacts is if you're within another individual for more than 5 minutes within 6 feet or 2 meters, that then you need to have PPE. Otherwise, you are considered exposed if that person turns out to be positive. Now, we have such a low incidence rate that, and we also screen everyone when they come in, both patients and staff. So we just do a temperature screen, and obviously with staff, we know their history as far as travel and things. But with patients, we have to ask them that every time. And that's our way of saying, okay, these are low risk individuals. And when you look at the CDC website about, identifying the different risk categories, we deal with low risk individuals. And a lot of the hype around COVID is very real because it's dealing with the high risk scenarios. When you see the hospitals where there's the epidemic where it's really bad, that's dealing with high risk individuals, and that's a totally different scenario than dealing with low risk asymptomatic screen patients in low incidence areas. So again, what I'm saying is for the incidence level is low. It may not be low where all of you are. For some of you, yes, others maybe not. And that's something you have to take into account. And if I'm, sitting at my clinic here, I have a very, somewhat relaxed view because I know we have so little incidence, no community transmission at all, really. Whereas if I'm going to be somewhere where there is, then I'm going to have more safeguards and be even stricter with what types of PPE. But obviously everyone has to wear eye protection. Glasses alone don't suffice. You have to have actual either a face shield or special glasses like we use, say, for the liquid nitrogen handling. And then we, of course, wear a mask, and we go through proper donning and doffing of that, and gloves when we are having to work with a patient or a sample. And we use scrubs and shoes that are specific for the clinic and are left there and are not taken home to be washed.
Okay.
So that's there's more than that, but I think really that's the definition of close contact, like what you need to do if you're going to be in close contact with someone, and it's whether it's your colleague or a patient, then you want to be sure that you've got your PPE that allows you to say, so when you think about someone that's doing contact tracing, if say your patient goes home and they say, oh, I feel sick the next day. Now the contact tracing, bureau, whatever it's called in your area, they're going to say, well, who did you go near? And let's trace that. And you'll be one of those people that they went near. And then they can say, well, how were you exposed? And if you had PPE on, officially, that means you're not a close contact exposure risk, and therefore you don't have to isolate. And and your risk of being infected is quite low. So again, we're dealing with low risk individuals. If they are shedding and they're wearing masks, very important, if they are wearing masks, then that makes it so that as long as we do all those things and we're very diligent about it, then our risk is slow. Because we also, the additional risk about that is we don't want to have to shut down our unit. So we want to protect patients, we want to protect us, and we don't want to have one of us get suddenly be considered infective and our whole team has to get shut down, and now we can't even provide the care.
Yeah, so this is a little bit about patients, and I'll come up with a few data points as well. So I was going through this infographic yesterday, which actually said that if you are wearing a mask and your patient is not wearing a mask, the risk of transmission is still quite high. It's around about 40 to 50%. If the patient wears a mask and you're wearing a mask, the risk of transmission is about 1%. And if the patient is wearing a mask and you're not wearing a mask, it's about 5%. So it becomes very important. It's not just us who have to take these precautions. It's our patients who have to take these precautions as well. So are there any kind of guidelines or flyers that you're sending out to your patients to actually, or instructions that you're sending out to your patients before they come into the clinic?
Yeah, of course. They are told, that they can only come in. So we have spacing going on, so we don't have a lot of people congregating. During the the worst part of, say, our experience here, and it's still occurring, I think, in Malaysia, is that the partner is not allowed to come in. So this adds another level of challenge to have a sample brought in, and some security issues that we have to consider. But so the patients are told all of this. They're told to wait in their cars. They'll be called when it's time to come in. Then they go to the lobby. They're let in. So obviously that process is there. They also have to answer the questions beforehand, and then we give them a mask. So it's not just that they can come in and wear some sort of face covering. We want to give them an actual medical, grade mask, just a standard one that we use in the lab all the time. We don't have to use the N95s, but that's what they're told up front, and they also have to get their temperature checked when they arrive at the front desk.
So obviously, a triaging has to be done for all the patients who are coming in.
Yeah, it's great.
And it is advisable that we do these, at least the questions can be asked online or using telemedicine or something like that.
Yeah.
So the exposure of the patient inside the clinic is less. Now, this was a little bit about the patients. I know we were talking about this when you did the webinar for the Monash group.
Mm-hmm.
How are you managing your staff? Are you screening them? Are you not screening them? Are you triaging them, et cetera, et cetera?
Right. So when we were in lockdown, so we started lockdown and our case numbers were going up, and we weren't sure if there's going to be community transmission. So everyone that was working would get screened temperature, which is it's not the greatest sensitivity or specificity, but it's really the only thing we have. When it comes to testing, it may be different in India, but here in New Zealand, the testing is quite limited to where you could only get it if the government said you met the criteria to be tested. And it wasn't something you could just say, oh, I'm going to do. I know in the US, because there's private companies that are offering it, you can just say, I'm going to go somewhere and get it done. And you can have your patients do that. But we don't have that ability here. So our staff, we just basically take their temperature and they put their PPE on. And we also had split shifts so that we had two teams, so that if somebody, became infected, we could continue to run.
And this is a daily exercise for
for the staff. It was daily, where you would get your temperature checked every day. Yep.
Yeah. So I think this is again going towards the new normal, that we will have to screen our staff, we will have to screen our patients daily. We can't be complacent here, because especially I'm sure New Zealand is controlled, but in India we still have the virus growing in certain parts of the countries. It's exploding in certain parts. So these are things that we have to be very careful about, especially when the travel restrictions actually end. Yeah. Now, there are a lot of questions about disinfection that are coming up. So cleaning of the lab in between cases, how should we go about it? Thank you, Saroj, for that question. Dean, what are your protocols for cleaning?
Yes. Well, and first I'd like to say hello to everyone that I'm seeing familiar names on there. So it's nice to see you all out there. Although I can't see you, I see your name. But as far as the cleaning of the lab between cases, we don't do anything special in that regard. And it's because when you consider what are the risks, and this is still my point earlier regarding we know so little about this virus. So fomite transmission is probably the thing we know the least about. And even though there was one paper that talked about how long the virus can live on surfaces, it didn't specify how much virus was living and whether there was enough actually to be transmittable. I'm going to go on record right now and say the only risk I'm talking about is to the staff and patients potentially, but not to the sample, because our universal precautions mean that and this is a respiratory coronavirus. This is not a STD. We don't have any concern with it regarding the samples themselves. Again, these are asymptomatic individuals. Very important point. So because of that, the risk within the lab is only when you get the sample cup with the semen, you know that there's a risk there could be something on the outside. So you obviously take extra precautions there, and you're cleaning at that point. But once that sample's out of that cup into a tube and being processed, now it's like any other sample. And really the aspiration tubes for the oocyte pickup really aren't at high risk. So things coming into the lab, it's probably the safest place there is in all of medicine, really. So the risks then between cases is the staff activity. And if the staff are all wearing PPE, then there isn't any other reason to have extensive cleaning between cases.
No, but
Mhm.
when we talk about I'm not sure what your protocol is for ovum pickups. I'm not sure if you're giving anesthesia for pickups or not. But when we talk about patients who undergo anesthesia, all of those things have to be cleaned up before we actually shift to a new patient. This is general practice, and I think this cleaning happens regularly. But is that regular cleaning sufficient, or do we have to be extra cautious when we actually start pickups? Because I know from the HFEA document, a time gap of 1.5 hours is actually being advocated between pickups. So, your views on it?
So, again, there's a couple different things about our setting that makes it quite unique. Well, not necessarily in medicine, but definitely say compared to wards in hospitals, we have a very high air exchange rate, or we should. I mean, you'll know if you don't have a high air exchange rate in your lab, then in your theater, then you might need to leave longer time. But there are guidances regarding what's your air exchange rate, and that influences what kind of turnover rate. And it's usually in our settings, it's really short because we have such high turnover rate.
Okay.
In the theater, obviously, as you said, so we stopped doing any sort of general anesthesia. We didn't want to have that risk involved, but we do have to still clean the facility in between each. And one of the challenges is if you're using one of the quaternary ammonium products like Fertisafe or Oosafe, they require a certain amount of time exposure to take care of the virus. So that's one of the things. The other part that I've advocated is actually that ethanol, 70% ethanol in the theater, when it's on a separate air handler, is got incredibly low risk of increasing the VOCs in the laboratory. So when we're talking about our safety, patient safety, if I was working in a facility where we had patients, where we actually would have the risk that somebody would call up the next day and say, yeah, I'm feeling symptoms. If I had that concern, I would want to use something that was really effective and that I knew people were using accurately, so properly. And the problem with the quaternary ammoniums is that when you're in a hurry and things, do they really use it properly? Whereas either H202, so hydrogen peroxide, or ethanol are the two really, least caustic, fast-acting cleaning agents. The problem with peroxide is that it doesn't always maintain its activity, so you don't know, how good your peroxide is versus ethanol that's outstanding. So I'm a big fan of saying, in this case, safety trumps this really, really, theoretical risk of ethanol increasing in our culture dishes when it's that far away.
Okay, and so there are questions about disinfectants as well, and we've been talking about it. What are your views on sodium hypochlorite? Because that's one of the most commonly propagated disinfectants in these times. And can we actually use sodium hypochlorite in the laboratory? I think it's safe in the OT, but Alpesh was talking about the fumes that were coming out of it. I'm not sure.
Yeah, I've not heard anybody using that in the laboratory, and I'm not a fan of it. Residue, smells, causticness. There's reasons to not. I think we can use other things better, and I do think, again, a brief exposure to ethanol. And let me just kind of clarify the ethanol story, because we know that it can result in egg activation when it's at 7%.
Yeah.
So, the amount used in the studies for activating eggs is 7% in the media. Now we're using 7%.
I heard that yesterday in the ICSI talk, which you guys conducted. So he was also talking about ethanol being used for oocyte activation. But carry on.
Yeah, exactly. You're right. Yeah. Carl Swan did. So, we know that there's a risk of getting ethanol, because ethanol will concentrate in our incubator humidity pans. And then once it's in the humidity, it's going to be in the air in the big box incubators. And then from there, it can get into the culture media. Now, the gradient from 70% in our bottles or wipes to the air to the pan, to the things. That's never been demonstrated what that is. It's theoretical that it could actually be a risk. So we avoid it because it, in theory, could be a problem. But that is, of course, and the reality is the majority of the clinics that I've ever worked in prior to 2010 used ethanol all the time. It wasn't like, it didn't, while it may have, diminished our rates a little bit, we don't know, but it wasn't, we were doing very well. So I don't have a problem with it in these circumstances. If you need to, if you have risks of actually saying, well, I got to wipe this down because we have a higher risk, then using some ethanol is appropriate, or getting a good source of hydrogen peroxide.
Okay. And would you have any different kinds of protocols for cleaning the OT or the lab, or is just the general way that we used to clean?
Well, so the OT obviously has to be cleaned completely between two cases, and that's where they wipe down. And our standard approach is to use something like OSAFE. And we, there's enough time in between cases, and that works fine. But we also run out of it. We also run into some times where now we're at a point where we're doing cases more frequently, and then it becomes a concern: are we actually getting it done well? So that's the theater. The lab, though, again, if you think about what are the risks, if we've taken away any risk coming from the patient because we've handled the sample cup, we've taken care of that. We don't think there's any virus on any of our materials in the lab. We've been wearing PPE. We washed our hands well before we went in. The only risk is anything coming from us as far as respiratory droplets. Now, that's always the case. It's not just in between cases. So, there's some people saying, well, when one person works on a microscope, it should be cleaned before the next person works on it. Again, with individuals wearing masks, and your point before about the risk of how much transmission is going on, we don't have enough information for it. If you want to be overly cautious, you could say, wipe down in between each. It's quite difficult to make sure you wipe down everything, all the manipulators and everything. I just find it really hard to actually, believe that there's enough virus present in that setting that you could pick up on gloves you're wearing and then somehow get into your, mucous membranes. So
what
I think
what we are thinking is so we have about 5 embryologists in our laboratory, and we've not started yet. But once we start, what we are trying to do is we're going to delegate the job roles to each embryologist. So if one person is doing the screening during the ovum pickup, he's going to do the screening for the whole day. If one person is doing ICSI, then that person does the ICSI for the whole day. So and plus we also are trying to minimize on the exposure with the dishes. So the person handling the patient's dish will only be looking after those dishes for the next 5 days or so. So that we try and minimize on the exposure a bit, because we are actually in Agra. I'll tell you a little bit about Agra. There are about 900 cases in Agra itself, and it's a small city. And now the private labs have actually stopped. The government has actually advised the private labs to stop testing, and it's only the government labs that are testing for the virus at the moment. So the number of the tests that can be done in a day is also restricted. So we don't exactly know how many asymptomatic carriers are walking around. We don't even know how many symptomatic people are there in the city at the moment. So that's why we are thinking that we're going to be very, very cautious when we actually begin the clinic.
Yeah. I mean, I think I've been really impressed with how India has dealt with this, and obviously Kerala is leading the way in that. It just really illustrates that with physical distancing and taking precautions, not having gatherings. You look at the majority of the bad events are due to gatherings and things like mass transit without masks, which obviously is a problem in the U.S. When you don't know it's there, if you're not taking precautions, it's a problem. So
can you imagine that scenario in India? We used to have social gatherings every night, and it's completely gone now. You've been to our conferences,
yes,
so you know
yes. It's got to be really, really challenging. So you have a lot of video gatherings now, huh?
Yeah, a lot of Zoom events which are happening.
Yeah.
I know one of my friends actually got married on Zoom, so
No way.
that's all happened. Yeah,
Wow.
I'll show you a few pictures of it. All right. So coming back to the discussion,
Yes.
any specific time interval that you're practicing now? I know you're in a different situation, but
Yeah.
if you're in our situation, what kind of time interval would you be thinking about?
I'm going to have to plead a little ignorance in that there's different guidances again that are based on your air turnover and how long that should be. And we typically we've just said we're at least an hour. We prefer 2 hours.
Okay.
I think that's
And what's the typical air exchange rate that we should be thinking about in the laboratory at the moment?
Well, we like to have like at least 15, but 20
15 to 16. Okay.
Yep.
Yeah, and that should suffice, and then you can come back within an
Yeah,
hour.
I mean, there's guidance on this, and I can try to find that and share it. I don't have that document pulled up.
Okay. And I know that you guys are not allowed. You guys are also not doing COVID tests for all your patients. It's only when they meet a specific criteria that they get tested by the government. And I think that's the same kind of scenario which is happening in India. In India, practices are changing every single day because like a few days ago, private labs were testing, but now they're not testing in our state at least. So we can't really say what to do, but there are a lot of questions on how to actually test these patients. Would you have any experience on how many tests that can be recommended?
Yeah. So we're not. I mean, this is like a non-starter for us. We don't do any testing. Testing is only done if somebody shows symptoms or has been exposed to somebody, and we want to make sure that they're not asymptomatic. So again, I think what they're doing 5,000, 3,000 tests a day here, and they get one positive, and it's from a cluster. Well, why would we test? And we never did, and it's just not practical to do it. It's very expensive, and it's if you're not showing symptoms, there's also a false positive rate with the test. It's not an assurance that you're safe to go forward. So it's a lot of extra cost to potentially still miss some. And to both the system, it's a cost, and potentially taking tests away from people that need it.
Okay, so I'm going to come back to what we were discussing earlier. Is there like a prioritization for your patients, and is there an exclusion list at the moment, or you're taking any and every case which comes into the clinic?
Right. So we always allowed fertility preservation, so any cancer patients, and we had those. Unfortunately, life goes on, and cancer still is a reality for people, which is a double whammy during this time. But we were able to freeze eggs, freeze sperm in the lockdown. But once we were locked down, we weren't doing anything else. Once we came out of the lockdown, then we did prioritize based on it didn't make as much sense to do IUIs when those individuals usually have some chance of conceiving still on their own. So IVF, where there's clearly no way they can conceive on their own, and older patients. And ones that were also, obviously waiting and their ovarian reserve becomes an issue.
Yeah. And what about patients who have like comorbidities, like who are highly hypertensive, diabetic? Are you actually telling them to wait for a little while till the situation? I'm sure this is again not pertaining to you because New Zealand has actually controlled the situation, but would that be a scenario that you could foresee?
It's a great question. I don't have an answer for that one because I don't believe we put anything in place for that, and I'm not sure that we have anything like that in Malaysia either.
Okay, so we're coming back to disinfection because I think there are a lot of questions about disinfection. UV. What do you feel about UV radiation in the lab?
Well,
between
for the theater, I wouldn't use it in the lab, and the reason I wouldn't use it in the lab is because it releases, all the plastics we have give off VOCs once they get exposed to UV, and I mean I've done enough air quality testing that I can tell you after we have our UV on, we see a pretty good spike in our box. If you need to use it in the theater, again, if I were in a really high risk area, which you could argue, are you really wanting to continue to practice in the high risk? But we work low risk. So with low risk, I think standard cleaning is fine. If it was medium risk, UV radiation should be fine. I just was watching a New York Times video where they were showing this system for UV radiation that I hadn't seen, for decontamination.
I also saw that. Yeah. There's a robo which enters into the room, switches on the UV light, and then goes back.
Yeah. So, I suppose obviously it must be effective. But I think, again, we're dealing with low risk, asymptomatic individuals who are wearing a mask. How much virus are we looking to actually clean out of there? I just can't imagine that it's very much.
I agree with you. And we have to understand that there is a certain viral load which is required for infection. And if we're maintaining standard protocols, if we're cleaning our labs regularly, we are minimizing that viral load, even if it's present on our surfaces. So again, UV in between cases, especially in between cases in the laboratory, is something that might not be advocated, if I'm right.
The only place that UV in my mind works in the laboratory is if you have it in a hood and you don't have anything in the hood except for potentially equipment but no plastics, then you could use it for that, but not anywhere else in the lab.
And any extra precautions with the consumables and media that comes into the laboratory? We clean them before, or what?
No, we remove them from cardboard, but again, the resounding evidence out there, and there isn't, there just aren't examples of transmission from, say, getting even the food from the grocery store. We're really lacking in any good examples of fomite transmission. Where fomite transmission is an issue is when somebody sneezes on a railing and you touch it and then you touch your face. Well, that's clearly going to be a case where there's enough virus that you then get on to you that you then can actually get into your in your system. When it comes to something that's been sitting for days or we don't know how long, of course I worry about this. Did the courier or the person that packed it, they sneeze on this however many days ago, but it's now dispersed, it's dried out. So we don't take any extra precautions other than always keeping, cardboard out of the lab.
Yeah, because I again remember that we were discussing this in the Monash webinar that we had a couple of weeks ago, where they were suggesting using alcohol wipes to actually clean the media bottles and then putting it into the refrigerators or something like that. Would that be routine practice now?
Well, again, I'm speaking from this position here in New Zealand where we don't believe we have much risk. If there's that much transmission going on, that there's potentially that much virus on these packed bottles, then I think we're really working in a different scenario. And then, I would say, okay, we know that there's a lot of transmission going on. Let's wipe everything down. But that's not an issue here. And I really don't think it's an issue, from most places. When you look around the world, there's hot spots. And other than that, I just don't think it's an issue.
Okay. Coming to some of these questions which are related to semen freezing and semen analysis. Again, most of the questions are related to testing, but any specific precautions while we're doing the semen analysis or freezing such samples? Should we be avoiding a lot of semen freezing at the moment and just use fresh samples? Again, what are your views on this?
So we're taking what I think a practical approach in New Zealand, and that is this is a coronavirus. The few papers that have come out have shown that it's not in semen, except this one paper from the JAMA that showed that it was there, but in very infected individuals. The reality is, and I always go back to this, if you look at what do the blood banks do? If this is a risk, then the blood banks should take biggest precaution, right? Because they have to worry about infecting other people, like with their donations. So if an asymptomatic individual goes to give blood and they complete the questionnaire and they pass all those tests, then they can donate.
Yeah.
And what we know is if you just want to share my screen.
Yeah, I can do that.
Yeah. So this is one of the papers that I've been tracking all along. So this came out of China, of course, and it's been a couple months now, I think, that this one's out. And I keep looking at this paper and looking for citations of this paper to see if anybody has come along to say that the blood supply is at risk. And the resounding answer, and I have a good colleague back at Mayo Clinic that used to run the blood bank, Manish Gandhi, it's not a blood-borne disease.
Yeah.
It's a respiratory disease. Therefore, it's not a risk if you're not in a point of disease where you're having breakdown of tissue and the release into the blood. So our patients who are asymptomatic are not. They're not going to have. And so this just is one paper I would say keep an eye on. You can do the same thing. You can say, has anyone cited this? Or you may find a better paper. It's one of the ways I track what's coming out. This paper, which is a research letter, I think in JAMA as well, from March 11th, but you see here 3 positives in 307 blood samples. I don't know if you guys can all see that, but of all the different types of samples they tested, sputum, nasal, feces, nothing in urine, and only 3 out of 300 in blood. And these are in individuals who are positive for the COVID.
Yeah.
And again, our patients aren't; they're asymptomatic. So for it to get to the testes, it doesn't happen until somebody becomes very, very sick. And so,
and when we're talking about the sensitivity of the test, like, could these 3 positives could be because of could that be a positive as well? Because it's a very small number.
Right, and 2 parts about that. One is it's a very small number that could be false positives, and the second is that it's only testing for the RNA. It's not testing for the virus. In fact, in this study, they looked at in these fecal samples, they were actually able to do transmission electron microscopy, TEM, to be able to demonstrate that there is some live virus, but not in all of them. So even though you get the RNA, you don't get live virus always. So that's another part of this story that complicates our interpretation of the risks.
Okay. All right. So again, any other precautions for freezing of semen samples as well as storage?
So I mean, I have these papers which show that there's no evidence of SARS-CoV. These are people who are infected. So this one is in fertility and sterility coming out. It's online. This one, which went to biology of reproduction, also found there wasn't any coronavirus in semen and testes. This is the one that did find some, but it was using individuals. I mean, some of these people weren't able to even provide a sample. They were so sick. And so this is the exception to it. And again, it doesn't represent our patients. So because of that, we've taken the approach in New Zealand that asymptomatic individuals coming in for freezing sperm or using sperm, there's no extra testing required. There's no extra risk with that sample because it's a coronavirus. It's not a sexually transmitted virus.
Yeah. And again, so we're maintaining regular tanks. We are not advising separate tanks for.
We are not. Right. Correct. No. We are sticking with, we have tanks for infectious, sexually transmitted diseases, but this is, again, a respiratory disease virus that, the blood banks, like I say, they're not viewed as a transmissible, sexually transmitted or via blood transfusion.
Yeah. There are a lot of new things which are coming up, and this is something that I've been tracking for the last 2 years, and that's sterilization of liquid nitrogen.
Yes.
Have you heard about it?
Oh yeah, of course. It's a hot topic. You can stop sharing. I don't think I need my sheet.
Okay, I'm going to remove that. Yeah.
Yep. So I see that, if we take it at face value, you'd say, oh, it makes sense. We know that we can detect virus and bacteria in liquid nitrogen. Therefore, we want it to be clean. And, now, ideally, if we're using all closed systems for our samples, then that's not an issue. But we don't here as well. We do for semen, we do. So we use the CBS high security straw. And from that standpoint, I think the risk is low. But what we don't know, what we do know is there's never been a documented transmission for reproductive tissues in liquid nitrogen. That's a given.
True. It's always been a hypothetical risk.
It's all hypothetical risk, and it's really minuscule. And there's some really good papers written by Kim Pomeroy on this that really, I think, make it a non-issue. It's theoretical, hypothetical, and we won't be doing any sterilization of liquid nitrogen because the other part that we don't understand is, when clinics freeze viruses, so virology labs, they have to freeze them just like we freeze our samples. They have to put them in special solutions to allow them to survive well. So freezing, having something in liquid nitrogen doesn't necessarily mean it's still able to transmit the disease.
So what are your views on the ACE2 receptors? Because I know there is a lot of research which has come out which says that these embryos can exhibit ACE2 receptors. So that probably means that the virus could actually internalize inside the embryo. So
again, it goes back to, the embryo is I think, going to have its own protective mechanisms, whether the zone is enough, whether just the fact that we dilute the samples out, just the evidence that we have from, women that have gotten pregnant with COVID, I'm not concerned about the embryos. The concern is real around the testes, less so the ovaries. The testes, when someone is really ill, and some of these studies, and I can just share again a couple of papers I've got if you want to share my screen again. So there are papers that are out there looking at the testes, and they talk about the similarity with other viruses. And the fact is that there's individuals. There's this one just came out in Biology of Reproduction, and the testes do have ACE2 receptors, and they do seem to be affected by the coronavirus in some patients. So, of the individuals where they test for semen presence of the virus, individuals would come in and say they have pain, scrotal pain. So it appears that it can, once it's systemic, it can affect the testes. And in this way, I would say we could look at it similar to mumps. So mumps does the same thing. And we know there's a small percentage of men who get mumps infection that have a reaction where they have inflamed testicles, and they actually have a fertility effect. But it's not a transmissible effect. So it's not a risk in terms of the virus itself. It's more of a risk to the person's fertility in the future.
My only question here, my only comment here would be, like, if the virus becomes systemic, these patients would not be walking into your clinic. These patients would be going into the ICU or somewhere else. So in asymptomatic patients, we should not be getting the virus inside the semen samples, in the follicular fluid, etc., etc. So and that's why following a good triage system, for doing your regular checks with your thermal checks and screenings, etc., should be sufficient when we are actually restarting the centers. All right. Any advice for banks?
So great question. Sure, dude. So what we're doing currently, we don't believe there's any reason to treat samples any differently that are donations. But because we're looking at a short window of time, we can easily quarantine them and know that that individual does not become infective in the next 14 days, doesn't show symptoms. So even though we know there's the possibility exists that an asymptomatic individual never shows symptoms, it goes away, and they donated during that time. Again, for the examples, for reasons you just gave, we don't believe that if it's not a problem for the blood banks, it shouldn't be a problem for the sperm banks.
So just social distancing between patients, and like having mini teams inside your banks as well, because I know that some banks might have a large number of people walking into on a particular day. So probably just managing social distancing protocols should be sufficient. And obviously, when we're talking about semen samples, they are quarantined for about 6 months. So we shouldn't really be bothered about like COVID in such scenarios.
Again, it's just like if I really, I keep going back to this, and it may sound like a broken record, but if the blood banks can use donated blood, and then we're talking downstream from the blood to actually get it into the semen, right? If that's so far-fetched that I have no reason to be concerned about it.
Yeah. Okay, so Atita has a question here. For vitrification, are we recommending now to do it in closed systems, or can they still do in open systems?
Yeah, we still use open. We only use open for oocytes.
Okay.
We use the high security HSV straws for embryos, and we use the CBS for semen. But with all of the evidence, the coronavirus doesn't change the story for how I view storing in liquid nitrogen, and the infinitesimal theoretical only risk of there possibly being some amount of virus getting from one spot to another in an effective dose. It's beyond comprehension.
Yeah. So going off topic here, have you seen a difference in the survival rates with oocytes when you're using open and closed systems?
We haven't done a comparison ourselves. We just are following kind of the global preference, which says that we think, we need the fastest warming rate possible. And we'd like the fastest freezing rate, but we really want the fastest warming rate possible. And that requires that it doesn't necessarily require it has to be open. But that's just the way we're kind of following the herd in that area, because it's we're still not where we want to be with freezing eggs. So we take every step we can to get as good of a result as possible.
Yeah, I've kind of modified the protocols a bit. And like in our laboratory, I try to actually do a serial equilibration of the oocytes so that they equilibrate a little slower as compared to
we're doing the same.
Protocols.
Those membranes are definitely sensitive, and they can lyse. And whether that's going to make a difference, we're playing with that as well.
Yeah. Okay, great. So I think there are about 5 minutes left. Let's go to a few questions that I had for you.
Okay.
We were discussing a little bit about social distancing. So how do you advise to actually make these mini teams which are working in the laboratory? Is it half your staff on a particular day or half on the other day, or you're actually doing more than that? I'm not even sure how many embryologists you have.
We've got a variety of clinics. There's 9 clinics total, 5 in New Zealand and 4 in Malaysia. And they're all of different sizes. So they all have their unique setup. Yeah. Now, of the 9, I think 1, 2, 3, 4 of them at least there's only enough staff for, one. It's a small clinics. They can't split the team. So that means that, you always run the risk that the whole team goes, and then we have to say, we'll ship, if we have to shut down that clinic, then we shift our services to a different clinic, which is not always possible. Depends on the distance away, because the flying obviously is out of the question.
But then having contingencies in place is something that is advisable in such a situation.
Yes. So the one is that we use our standard emergency preparedness, disaster preparedness protocol, which is we vitrify everything if we have to. So if for some reason suddenly we say we got to shut down today because somebody's, we're not allowed to work, then we have to be able to do that freezing, that quick vitrification. But otherwise, it's backup plans. And so in our bigger clinics where we have 8 or more embryologists, we can have 2 clear teams. And then working alternating days is how we've done it. In New Zealand, we've done week on, week off, I believe, in Malaysia. So it varies. We looked at the possibility of doing early and late shifts, but then you have the cleaning in between, and just the risks that are involved with that, and how well that you can manage patients, and it becomes a bigger issue for the rest of the clinic, like the doctors and the nurses and managing all of that. The other thing we ran into, which is a real challenge, is saying we want the whole team. We want a doctor, nurse, and embryologist as a team, preferably, but it's quite difficult to do. So it wasn't always possible. We would definitely have the two lab teams separate, since it's such a critical component.
But even when we're talking about the laboratory, at least 2 embryologists in the laboratory at all times?
A senior and a junior. There's always a senior on each team.
Yeah. All right. A little bit about quality assurance. Any specific things that you're doing regarding quality control during these times? Specific data that you're recording or something like that?
Right. No, we track all of our KPIs as usual. The fact is, unlike you guys, we didn't have 2 months of shutdown. So that puts, if I put on a different hat, if I'm, working in India or wherever, and I've got 2 months of my lab being closed, then I definitely have more concerns about making sure all my equipment is functioning properly, is tested. I mean, we used to use mouse embryo assays in the U.S. quite extensively, but human sperm survival assay, you're going to do a deep clean potentially. I don't see a strong need for a deep clean. The lab is sitting quiet. It can just be your standard cleaning process. But then again, if you're due for your, if you do a routine deep clean and you can fit it in, then that's a good time to do it. But otherwise, that's the crux of it, is you want to make sure your equipment and your, all of your parameters are in place and functioning well before you start doing patients.
So when we're thinking about 2-month shutdown, now, like in my laboratory, all my equipment was on, all the gases were connected, etc., because we always keep them on. We never shut it off completely. Mm-hmm. And this was a specific situation for us where there were no patients for 2 months, but we still kept the equipment on because we were worried about like recalibration and the access to engineers, etc. So we kept everything on. Mm-hmm. But for people who've shut their labs down, would you advise like doing a small burn-in of the laboratory to eliminate VOCs, or checking the VOCs, checking the CO2s, all of that?
Well, so it's I don't advise a burn-in. A burn-in, is for totally different reasons. I do, if you have plumbing in the lab, that's one of the more risky areas that we're now seeing for a lot of places that are returning to work, is that, we want to make sure we have the plumbing flushed well. We like to flush the lines, the gas lines a bit if it's been sitting, because you don't know how well that's mixed. I mean, it should be fine, but we just, for precautionary measures, really just letting it run for a few days before you start, and then doing your QC. And hopefully you all have the ability to measure CO2 and O2, and you have good temperature probes to, So what we did, we wanted to conserve gas, particularly the tri-mix gas that we use for our, say, minks or the planar BT37s. And in that case, we just turned off the gas flow to them.
Yeah.
And of course, now putting them back in. Yeah. And so then we could turn that back on, and we use pH indicator dishes in each side, and that just gives us our visual confirmation that we're getting a pH, in the ballpark where we want it to be. We can't, it's not exact, but it's at least a visual check. And then of course, checking temperatures. If you turn something off, you would obviously want to check the temperature when you turn it back on.
Yeah. And like you mentioned, like if you have access to semen samples, you can do a sperm survival just to be very, very sure, and then like start resuming your practices.
Yes.
Okay. I think we'll take one last question before we summarize. PPE mandatory for everyone inside the complex? And is there different kinds of PPE that we are talking about in different areas?
Right. Well, it's a great question. It's one that we've gone round and around with because, it's all a question of how much risk is where you are. And here our risk is low. So it's really difficult to enforce all this extra measures when you're like, but there's no incidence here. So it's difficult. But I would say the thing we know for sure about this virus is that it's mostly transmitted through droplets, and therefore a mask is like the most critical piece of PPE. And that, yes, we have, even now we're in alert level 2, I think. Yeah, we're in alert level 2, which means that basically everything's open. We just don't have large gatherings. So nobody over, I think, 10 people. And we still wear masks, in part because we're in a healthcare setting, but also because we don't want to take the chance. So it's a little bit, I think probably more than is absolutely needed, but that is the minimum I would say you'd want to do.
And how easy is it working under PPE, especially the goggles, especially if you're
Yeah.
wearing the full suit? It's not going to be easy doing embryology procedures.
Well, so we don't use full suits. That's like if you're working in an intensive care unit where you have infected patients and a full suit is necessary. Where we're using scrubs that we can, take and get washed. And then we also, you raise an important point, because if we potentially, if you don't normally wear gloves when you're working in the lab, if you don't normally wear a mask, and suddenly it's always fogging up your glasses or the eyepieces, suddenly that's changing how you work, and it raises the chance that you're going to have an error or mistake happen because of the PPE. Particularly, say, handling samples with gloves, like when you're moving dishes. If you don't normally wear gloves, it can get sticky. It's a risk. And so I've been flexible on that. Not on the mask, though. So.
Okay. And again, probably my advice here would be to just get accustomed to it before you start or doing your cases. So try like shifting the dishes or empty dishes, using the gloves.
Yes. Yep.
And like get accustomed to like wearing the goggles and visualizing something, etc., etc. So these things can be tried before you actually try it out on patients.
Absolutely.
Is New Zealand offering home collection for samples and
yes,
even Malaysia?
Yes, definitely. Home collection is really a helpful thing when we were worried. Now, of course, we have to balance that against the sample integrity risk. But the question I saw was about cleaning the rooms between, and we would clean them just like the theater, where we would use OSafe or any other of the cleaning agents and do a full wipe down. And there'd be at least an hour between cases, between samples in the collection rooms.
Yeah. Because like we were also talking about this yesterday, because now we've started training our staff to get accustomed to these new protocols. And when we went to the semen collection rooms, we were like, okay, so there's a bed here, there is a bed sheet on it, there are pillows, there are pillow covers. How do we clean all of it? Do we change it after every turn? If we are getting 10 samples a day, do I need 10 more bed sheets? It was quite of a difficult scenario for us, and we didn't expect this to be a difficult scenario. So,
yeah, that is. It depends on what kind of equipment you're using in the room. In that regard, like whether it's the paper covers versus the cloth, and everybody's different in that regard. So it makes it a challenge.
All right. So there are a few more questions. If you can take some, I think another 2 minutes. PPE, can PPE create VOCs? I'm not sure.
No, we don't worry about that. I mean, I've worked in a lot of labs where we use, the gloves are there's a little bit of a smell to gloves, and we know sometimes we don't use we use the nitrile gloves for patients that are, and they all have a little different odor, but that's very minimal amount of VOC, so we don't believe it's a problem. And then the mask doesn't have VOCs. The goggles don't. They're hard plastic.
Mohammed here has a good suggestion. So in the semen collection room, we can probably use UV in between collection, right?
Sure.
That's a good.
Yeah, if you've got, I don't know enough about using a UV lamp in that a mobile setting to say how long. One of the concerns about UV lamps is that they have to be certified. Just because it's showing you, you don't look directly at it, but just because you see that it works doesn't mean that it's actually sending out the right wavelength light to be effective. And that's why we get them certified. And I don't know these mobile ones, how well they maintain that. So it's a whole nother area of quality control that I have no knowledge about and would be concerned with.
So again, I think advising the patients about proper hygiene, proper precautions, like if they're coughing or sneezing, they sneeze in their elbows or cough in the elbows, like general hygiene stuff. If you counsel your patients, and if their patients are honest with you when they come back and say, okay, this happened inside the collection room and probably you'll have to clean it, etc. So in those cases, you probably do a deep clean or you actually take more precautions, but otherwise general cleaning of the rooms should be sufficient again. And thank you to Mohammed for joining us. I think he's from the Middle East. I think he's from Egypt. You have fans from Indonesia who are watching as well. So they've written.
Okay. Hello. Nice picture. I like it.
Okay, so last question. I think we've not spoken about this, but I have spoken about this in the previous two. When we're discarding these samples, follicular fluid, semen samples, etc., dilution is the key here before discarding. Are you following those protocols? No.
Not at all. No.
Okay.
Again, it's not a sexually transmitted disease. It shouldn't be in follicular fluid. It shouldn't be in semen. All the evidence points to it not being present.
Okay. Okay, fantastic. So, Dean, last few takeaway points from you, just to summarize.
Yeah, just keep scanning the literature. We're learning more. You want to keep your eyes out for what could potentially change and require us to do something different. Follow your own local guidelines and wear PPE, wash your hands, and be safe.
Awesome. And again, I really feel that there's too much panic regarding COVID. We are all doctors here. We have access to PPEs. We have access to literature. We can think of restarting just following the state guidelines here. We can think of restarting. So if your government is allowing it, do restart. But again, ensure that you are taking all the precautions. You're triaging, you're screening your patients as well as your staff. And hope all of you would be able to do this. Hope you will be safe. And hope we can all go back to our laboratories very, very soon. So thank you so much, Dean, for joining us all the way from New Zealand. And hope we can do more sessions together. This was fun.
Well, yeah, I enjoyed it. Thanks, Keshav. Great to see you. And thanks for the invite. Thanks, everyone, for showing up.
All right. So have a good day, everyone, and hope to see you all soon. Bye-bye.